Hello guys, welcome to our channel. Today we will be discussing of the dermatology rapid revision as part of our Vision to 100 plus and for the upcoming June Fmge examination. So those who are new to this channel, please do subscribe and share with your friends. If you want to avail these notes, please do join the Telegram group and text me in the Telegram. So let's start the session, guys. So we will be discussing the most important topics. Let's start with the discussing who is a great contributor of the dermatology. So when we discuss who is the great contributors for the any subject, if you take, it is a very controversial. But some of the faces they are like one of the best contributors. They have done the very best innovation in this field. Okay, one among them is you might have heard he is Fitzpatrick. Okay, so Dr. Fitzpatrick is an American scientist and also he is a dermatologist and he is one of the most celebrated person in the modern dermatology. And one of his greatest discoveries is melanoma. How the melanoma is started, what is the risk factors. Over the time, his researches has helped the melanoma diagnosis and the treatment and prognosis. So for that, his contribution to the modern dermatology is much bigger than the larger area. So let's start the discussion, guys. First we will be discussing of the basics. So okay, basics is very important when you are discussing because some basics facts can be asked as a examination. You all know that dermatology is about skin, right? Dermatology is about skin. So first fact, that largest organ of our body is the skin, and skin consists of the three layers. One is the epidermis, which is the outermost layer, okay, followed by the dermis, right? This is the second most layer. Okay, next third one is the hypodermis. In the hypodermis, you will be having the subcutaneous tissue, right? So epidermis is the epithelium, dermis which will be having the collagen and the dense reticular tissues, and the hypodermis which will be consisting of the whatever the structures that the fat, fascia, everything will be present in the hypodermis. And the first thing that you have to remember, the dermis is which will be having the more vascularity comparing to the any other structures. Okay, so dermis will be having the more vascularity. So next move on to the different layers. So if you want to remember the different layers, just remember the mnemonic, come let's get sunburn. Okay, come let's get sunburn. So every first word is going to tell us a layer. So C for corneum, this is a most uppermost layer, and L for lucidium, G for granulosum, S for spinosum, and B for basale. These are the important levels that you have to remember. Next, important points if you have to discuss. This lucidium is very much translucent. Okay, this is very much translucent. That's why it is present in the palms and soles. This is present in the palms and soles. Next, coming to the stratum granulosum. In the stratum granulosum, you will be consisting of the granules. For example, here you can see this is the granules that you can observe here, right? So what are the granules it contains? It contains of the lamellar granules. It contains of the lamellar granules, and along with that, it also consists of the another important granules that will be known as a keratohyalin. So why this keratohyalin is important? Because keratohyalin contains of the filaggrin. So these filaggrin is help us in maintenance of the epidermis. If this filaggrin is deficient, let's say this is deficient, it can develop the atopy or it can develop to the ichthyosis, right? Ichthyosis, scaly skin-like lesions that may be present if it is absent. That is consisting of the keratohyalin structures. Next, spinosum. Spinosum, which will be the most spinal layers, and it will be consisting of the one point we will be discussing the next, that is the Langerhans cells. Next, basale, which will be consisting of the skin receptors, melanosomes, and also some other important structures surrounding to the dermis layer. And there is a question that is asked, which is known as a Malpighian layer. Okay, which is known as a Malpighian layer. So Malpighian layer is known as spinosum and basale. If we combine with this both, we'll call them as a Malpighian layer. This question can be also asked in the examination. Next, coming to the what are the cells and what are the important points that you have to take note. Keratinocytes. The whole epidermis, the majority, okay, the most abundant is consisting of the keratinocytes. And why this keratinocytes is important? Keratinocytes is important for our body so that it can maintain the support. Okay, it will maintain the support and also structure. This is the one point that you have to remember. Next, remaining all the cells, if you see the granules, other cells, any other cells, they are non-keratinocytes. Only the keratinocytes is most abundant. Let's say at least 80% is present in our body. Next, coming to the another cells. For example, let's say Merkel cells. Merkel cells is nothing but mechanoreceptors. This will sense the cells and the whatever the sensation that we get, that will be decided by the Merkel cells. That is a one point. Next, we will be discussing here another picture. This is an electron microscopy of the picture that cell is present in the skin. These cells is known as a Langerhans cell. This cell is known as a Langerhans cell, and this is derived from the mesoderm. This is derived from the mesoderm. And where it is present? It is present in the spinosum layer. It is present in the spinosum layer, and also it works as a macrophage of the skin. It will be working as a macrophage of the skin. It will be presented. So on the electron microscopy, if you see this one, how does it looking like? It is looking like a racket. Okay, tennis racket. So we call this as a tennis racket appearance. Tennis racket appearance. But in the general, if you see, this contains of the small granules, and these granules are known as a Baerbech granules. Baerbech granules. Can these patients have the association with the deficiency of this one? Yes. If there is a deficiency, the patient can suffer from the Langerhans cell histiocytosis. Histiocytosis. This condition. This will include bone marrow dysfunction and also skin. Okay, bone marrow dysfunction means it can also affect the hematology of the patients. That will be also seen. So this is a disease. But how can I test? I can see clearly this in the electron microscope. Is there any specific markers that is present? Yes, the markers that is present here is the S100. It can be asked a potential question, and CD207. CD207. This question can be also asked as a potential. These two markers are considered as a marker. Next, coming back to the mechanoreceptors, we have the different types of the mechanoreceptors in our body, right? In that, we all have to understand the first point about the skin. In that, we will be discussing of the Merkel disc one, and also we will be discussing of the Meissner corpuscle, Pacinian corpuscle, and the Ruffini endings we will be discussing. Let's discuss about the Merkel's disc. Okay, let's take this picture here. Okay, let's discuss. So what does this Merkel disc or the Merkel cells will be doing? So they are slow. Okay, they will be slow. And when you see this Merkel disc, this is actually in the basale layer, right? This is present in the basale layer. And what does this Merkel cells will be doing? They will be doing the neurosecretory function. Okay, they are neurosecretory function, and they will tell us the touch. Okay, especially in the edges, and also especially in the 2 point discrimination. And you may all have heard in the childhood also Braille script. What is mean by the Braille script? Whoever is the blind people, they can have this Braille script even without opening the eyes, or even with the blind people, they can uh, sense the with the edges and the touch of this Braille script. That is also comes from the Merkel disc only. Next, we have the Meissner corpuscle. What is the Meissner corpuscle? This is also some of the touch receptors only, but these touch receptors are fast, and they are superficial. They are superficial in present, and they also helpful for the light touch. They helpful for the light touch. Only the simple touch when you feel like mosquito is on your body, that might be due to the Meissner corpuscle touch. Next, Pacinian corpuscle. Pacinian corpuscles are deep. They also are fast. They also fast. Here you can see this is a deep, and this is going to tell us about the pressure. Okay, pressure. And also it will tell us about the vibration. Major vibration and pressure will be sensed by us. For example, our phone is vibrating under us. That means that vibration is felt by the Pacinian corpuscle. Next, Ruffini endings. Ruffini endings is also present deeply. Okay, and it is very slow. So here you can understand these two, the Merkel disc and also Ruffini endings, they present in the basal layer, and they both are slow. Okay, they both are deep and they both are also slow. That is one thing. And the another thing is there will be sensing at the stretch. Okay, if the stretch receptors is present, that is due to Ruffini endings. Next, another question can be asked potential. Where is this Merkel disc can be evolved? Merkel disc is evolved from the ectoderm. Merkel disc is came from the ectoderm origin. Next, skin, the skin layers is also where is the origin? Ep Epidermis is from the ectoderm. Epidermis is from the ectoderm, and dermis is also from the mesoderm, same like the spinosum, Langerhans cells, and hypodermis is also from the mesoderm. Okay, this is the points that you have to remember where is their origin. Next, another one that you have to take note is the melanosomes, right? Melanosomes. Let's see what is the important points about the melanosomes. Okay, so when I say melanosomes, how these are important? For example, this will decide us what is the pigmentation of our skin, right? This will decide us what is the pigmentation of our skin. That's why it is secretion also melanin. This will secrete the melanin. And how can we test? Same, using the S100 and HMB, okay, HMB45. These are the sensitive markers that we can test, and if ever the patient have condition that can consider as a melanoma due to high secretion of the melanosomes. And what is the enzyme that is most important? That is tyrosinase. The enzyme that is important for the melanosomes is the tyrosinase enzyme. And where is the origin it is coming from? These are origin from the neural crest cells. These are origin from the neural crest cells. This is the important points that you have to remember about the basics of the skin, right? Next, what we have to take note in the basics, the histology part is also important. But when histology questions is mostly focused on the pathology and other subjects, you can just know about the histological features of the only specific conditions. That is fine, not to know about the complete details of the all subjects, but you can know about the some subjects. That is fine. Next, some of the diagnostic tests we will be knowing. So diagnostic test, here you can see this is the picture of the wood lamp. This is the picture of wood lamp. So what does this wood lamp consisting of? Wood lamp will be testing us whether the patient is suffering from the any other conditions. But what is used by the wood lamps? This is used UV light radiation, and these UV light radiation on the skin we are going to put. This is a completely non-invasive. You are just putting like a torch light on the skin. And how much wavelength it is going to use? It is going to use the 364 wavelength. It is used by the wood lamp. But some of the important points that you have to know, how the difference of the different conditions is having the different colors. Okay, different conditions is having the different colors. Let's see. Let's take the patients who is suffering from the tinea infections. Here only we most commonly use in the OPD settings. In the tinea patients, in the patients of the tinea suffering versicolor or any other conditions, they will be having the blue-green color. Okay, there will be showing of the blue-green color. Next, another picture is the pityriasis versicolor. This is also another fungal infection. This will show the yellow color. Okay, next, erythrasma. This is a bacterial infection, and this will show the coral red appearances. This will show the coral red appearances. And vitiligo. Vitiligo will show us the white color. Okay, this is like a blue color only on the skin, but when we put this blue color, there will be some of the coral red color, blue green color, yellow color. If you see, this is associated with these conditions. Next, here you can see this is the slide test. This is known as a slide test, and in this slide test, what we are going to do? This slide test is mostly diascopy. Okay, this is known as a diascopy, and this is the patient who is suffering from the erythema. This is the patient suffering from the erythema, and here this patient is suffering from the purpura or PTK. But how I differentiate it? But when you use the slide on pressing, when you press, the skin is behaving like it is blanched, right? This is seen with a pale color. But when you blanch, when you press and when you blanch, this purpura or extravasation of the blood, any lesions, that is not going to blanch. So that is the difference between the diascopy, that is blanching, and from the difference from the other lesions. And apple jelly nodules. Okay, apple jelly nodules in seen in which conditions? Apple jelly nodules is seen in the skin TB patients. It is seen in the skin TB patients. Next, what is this picture, guys? This picture is about the phototherapy. Here in the phototherapy also we will be using the UV light rays on the different conditions. Most commonly we will use for the psoriasis patients, vitiligo patients, because these two are autoimmune conditions. At least to prevent the complications, we can use the UV light rays. And UV light rays is going to have the two types. Most common is the PUVA. Most common is PUVA, also known as a Sorlin. And how much wavelength that the PUVA will be consisting? It is consisting of the 320 nanometers. And what are the rays it is going to use? It is going to use the UVA rays. It is going to use the UVA rays. This question can be also asked. And what are the conditions? Psoriasis. Most commonly psoriasis patients who are affordable, they can use the phototherapy. Next, coming back to the Langerhans cells and the Blaschko cells. What is this Langerhans cells and the Blaschko cells? The Langerhans lines, I'm sorry, not the cells, Langerhans lines. These Langerhans lines is present with the collagen fibers. Okay, they are parallel to the collagen fibers. And also we can say this is the tension lines. These are tension lines. So better for the incisions. Okay, better for the incision because it can cause a less scar, because it is going to have the less scar presentation in the patients, right? Next, Blaschko lines. Blaschko lines is about the embryology of the skin. Okay, this is how embryology of the skin is developed, that is going to tell, like epidermal cell migration. It will be telling us epidermal cell migration in the different parts of the body. For example, if you see in the back, it is going to be in the V shape. In the legs, it is in the horizontal shape. And also here you are going to see the all appearances. So that is what we are going to differentiate with the Blaschko lines. This is not important for the collagen, skin lesions, any other thing. But if this Blaschko cells is defect, if these Blaschko cells are defect, so we are going to present with the patients of the incontinentia pigmenti. This is going to present with the incontinentia pigmenti. That is one point about the Blaschko lines and the Langerhans lines. Next, you have the difference of the skin lines, sorry, skin lesions. So these all are going to be the primary lines, primary skin lesions. For example, nodule, cyst. Cyst is consisting of the fluid. Okay, this nodule is solid structure. Okay, more than 1 centimeters, and same as a cyst is also more than 1 centimeters, and bullae is also more than 1 centimeters, but it consists of the clear fluid. Okay, clear fluid. And macule can be two times. Okay, macule most of the times it is less than 1 centimeters. And also plaque is also skin lesion which is more than 1 centimeter, seen in the psoriasis of the patients. Wheal is more than 1 centimeters, and vesicle is less than 1 centimeters, and also pustule which is less than 1 centimeters, but it consisting of the pus. Okay, these are the different types of the primary skin lesions. Next, we also have the secondary skin lesions. Okay, these are the secondary skin lesions. We have the ulcer, which can be breakdown of the epidermis or dermis, or it could be subcutaneous also. Fissure, it is break between the epidermis and the dermis. And the scaling, the patients who is having the severe skin condition affecting the epidermis, that is due to scaling. And the lichenification of the chronic itching. Erosion is due to the any structure that is caused the erosion due to the friction. And atrophy, that the skin is went to the atrophy. And the question that is asked for the scaling, where you are going to see the Brani scaling. Brani scaling is seen in the pityriasis versicolor. Okay, and where you are going to see the colorate scaling. Colorate scaling, you are going to see the pityriasis rosacea. Okay, don't confuse this between these two. Brani is versicolor fungal infection. Colorate is the rosacea, which is a viral infection. Next, coming back to the skin conditions, there are the many skin conditions that you have to take note of important points. So first and foremost is a non-impetigo. Okay, non-impetigo, or we can also say non-bullous impetigo. Is a non-bullous type. So what the patient will be presenting, most of the patients who is considered as age, let's say 5 years of old, patient will be presenting with this color of honey color crust. Okay, so honey color crust is also secondary lesions. So basically the patient will be having the other symptoms also, like systemic conditions like fever, or the patient will be having the other inside the skin lesions like pustules can be also seen. And the question that can be potential that is asked, what is the patient is going to have the organism involved here. So the organism is involved here is a staph aureus. Staph aureus. And how can we treat the staph aureus? Basically we can give the topical for the patient. Okay, topical such as mupirocin can be given. But if ever the patient is severe pyogenes or any other infection, it can convert as a for the post streptococcal glomerulonephritis. Next, bullous impetigo. Okay, this is the bullous impetigo, or we can also say this is the infection impetigo infectiosum. Overall, the most common is bullous impetigo, and here also involved is the staph aureus. Okay, overall it is also involved by the staph aureus only. So the very, if you observe, it is a flaccid bullae, okay, tension bullae, and the patient who is suffering from this bullae, it is very painful. It is very painful in the children, and it can rupture also. Okay, it can rupture also, and it may involve oral lesions or the skin lesions, anal lesions, trunk also. And for this patient, you have to give the oral antibiotics. For this patient, you have to give the oral antibiotics. Next, moving on to the erysipelas and the cellulitis. So this is the condition the patient is suffering from, the erysipelas, and these erysipelas condition is a superficial condition. Okay, this is a superficial condition, and this will be involving only the lymphatics. Okay, this will be involving of the difference of the lymphatics, epidermis and the dermis. And what is the most common organism? This is a group A streptococci that is involved in this patient. And how you are going to differentiate it? Here you can see this, you can demarcate, right? So here the borders will be regular, or other words, it is demarcated, okay, raised and red color. Okay, and we can also say this is a mild condition. It will not involve the further, it is a mild condition. It does not involving of the severe sepsis cannot be caused by this. That is the erysipelas. Next, cellulitis. Cellulitis itself, if you observe, it's look like a very severe condition. So it is a severe condition, but cellulitis patients is having the triggering factors. Most commonly these patients will be having the triggering factors. More that one of them is the diabetes mellitus, or the patient is having some trauma. Okay, these two can be seen. And what is the involvement here? It is going to involve the deeper dermis. It will be involving of the deeper dermis plus subcutaneous tissue. So the subcutaneous tissue is classically involves the cellulitis, and most common organism is the strep. Okay, the most common organism is a strep, followed by the group A streptococcus and also Staphylo aureus. It could be polymicrobial condition, especially if the patient is immunocompromised. And how you are going to differentiate? It is very ill demarcated. Okay, it is a very ill demarcated and irregular borders. Irregular borders. Patient will be having the severe pain and sometimes sepsis if it is progressed to the beyond the subcutaneous tissue. So where you are going to feel the redness, tenderness, okay, and warm on the physical examination. What you can do, you can treat with the empirical antibiotics. If it is progressed, then you have to go for the surgery of the cellulitis patient. Next, another condition that you can see here. So this question has been asked many times. So this condition is known as a staphylococcus. That means your organism you already know. This is caused by the staphylococcus. And scalded, scalded means skin scaling and the skin syndrome. Okay, so name itself tell it's all the features also. Staphylococcal scalded skin syndrome. It is seen in the newborns, or it is seen in the infants who is having the history of the staph infection. A staph aureus is one among the most common factors, and these staph aureus which will be producing of the exfoliative toxin. These exfoliative toxin like A and B serotypes, they are going to attack the desmoglein. They are going to attack this desmoglein at their injunctions. When this desmoglein is attacked on the epidermis, it is going to make the split. Okay, so the epidermal splitting is seen here. And what is positive here? So the Nikolsky sign is positive. On the normal skin, if you see the breakage, that is what Nikolsky sign. This Nikolsky sign is positive in these patients. So this is a Staphylococcus scalded syndrome, and other name for this is the Ritter's syndrome. Okay, other name for this is the Ritter's syndrome or the Ritter's disease we can call. Next, bacterial infections. Here you can see these are the three different which is commonly caused by the Staphylococcus aureus only. Okay, so this is also caused by the Staph aureus. What are those? Folliculitis, especially in the groin hair region. You're going to see the pustules, vesicles you're going to see, which is less than 1 centimeters. And if it is progressed, it can cause the furuncles, which is more than 1 centimeters, and it can cause the carbuncle also more than 1 centimeters and more than one carbuncle. Not just one, it could be more than one, but it is not a lymphadenopathy. Don't confuse with the lymphadenopathy. Carbuncle is consisting of the more than 1 to 2 carbuncles at one side with the pus discharge, and these are most commonly seen with again immunocompromised diabetes mellitus patients. What you can do, incision and drainage for this, topical antibiotics for this incision and drainage, and antibiotics which can be given for these patients. Next condition, so this is the erythrasma. This patient is suffering from the erythrasma, and erythrasma patients is most commonly bacterial infection. Okay, this is a bacterial infection. What organism is involved here? So the organism is involved here is a Corynebacterium minnesota. Okay, Corynebacterium minnesota that is involved, but I will be confusing this with the fungal infection. So fungal infection, we will be doing the KOH mount. KOH mount is negative. Then we'll be performing of the wood light wood lamp test, and on the wood lamp you are going to see the coral red appearances. Okay, so classical coral red appearances where you are going to see this is seen in the Corynebacteria. And what about the KOH? KOH is negative in this patients. KOH is negative in this patients. And next I wanted to understand you guys about the Nikolsky types of the signs, because Nikolsky types of the signs question has been asked in our examination, recent examination. This question is asked. So as I said, the Nikolsky sign, this is a true Nikolsky sign that is positive in the patients of the Staphylococcus aureus syndrome. We also have the other. Okay, so I will be writing here. So we have the true Nikolsky sign, true Nikolsky sign, and we also have the pseudo Nikolsky sign. Pseudo Nikolsky sign and false Nikolsky sign. False Nikolsky sign. And where these different signs will be seen. This is a match question that is asked in the INICT. Staphylococcus skin saldate syndrome, where you are going to see, and also Pemphigus syndromes, Pemphigus vulgaris, we are going to see this one, and pseudo-Nikolsky sign. This is seen in the Steven-Johnson syndrome and the toxic epidermal necrosis, and false Nikolsky sign is seen in the bullous pemphigoid. Those who are new to this channel, is seen in the bullous pemphigoid patients. This is seen. So these are the conditions where you are going to see these different types of the signs and their associated conditions. Please do remember that as well. Next, moving on to the viral infections. So in the viral infections, here you can see these two pictures is also image based questions is asked, guys. What is the first picture that you are seeing here? This is the patients who is suffering from the cold sore. Okay, this is the cold sore, and cold sore is seen in which patients? Cold sore is seen in the viral infections patients, and especially this is caused by the HSV1. This is caused by the HSV1 patients, herpes simplex virus 1, and this is caused by the herpes simplex virus 2. And what is this lesion? This is the vulva where you are going to see the vesicles. Okay, this is most commonly related to the STD, and this is due to oral secretions or droplets the patient is suffering, and this condition is known as a oral labialis or the herpes labialis, which will be called as. And it is associated with the STD. Yes, it is associated but less common, but the more common STD is seen in the genital lesions only. And where it is concerned, this virus is actually going to have the latent phase, where this latent phase will be seen more nearer by to our lips, which is the nerve that is more nearer, that is trigeminal. Okay, trigeminal nerve, which is going to save this herpes simplex virus latent phase. And coming to the herpes simplex virus, where it is going to save, it is near to the pelvis, right? So pelvis, which contains of the sacral vertebrae, so sacral ganglion, which will be saving of the herpes simplex virus too. And these lesions are recurrent lesions and highly infectious to the other patients. Okay, highly infectious to the other patients. This is asked in the FMG, this is asked in the recent INA CT. Next, coming to the zoster virus. This is known as a herpes zoster, where you are going to see this kind of vesicles, erythema, severely painful patients. This is known as a herpes zoster virus, and this is unilateral. Most of the times it is a unilateral, and it will follow the dermatomes. And in this, we can see this is a thoracic dermatome, which is the most common, and patient will be having the diabetes mellitus, who is not have exposed to the any virus before, and she is now developed due to immunocompromisation, and HIV patients who is positive for this. And also these are very painful lesions. Okay, these lesions are very painful lesions that is going to see. And where you are going to see the last latent phase, varicella zoster virus. So varicella zoster virus is present in the dorsal root ganglion. This is present in the dorsal root ganglion. Next, and it is can complicate with the some of the syndromes such as Ramsay-Hunt syndrome. Okay, Ramsay-Hunt syndrome, where you are going to see the herpes lesions on the ear with this dermatomal loss, or it can be also progressed to the patients with a different kind of sensory neural hearing loss also. Next, it can involve the ophthalmos. Okay, ophthalmic sign can be seen in this patient. These ophthalmic sign, which will be associated with a nerve. What is that nerve? It is going to involve the nasociliary nerve. It is going to involve the nasociliary nerve due to zoster virus, where you are going to see the lesions on the nose, and eye blindness can be seen in this patient. So this sign is known as a Hutchinson sign. This is known as a Hutchinson sign on the herpes zoster virus. What is the treatment of the choice for this patient? And treatment of the patient of the herpes zoster, we can go for the acyclovir for 5 days. Acyclovir for 5 days, 400 to 500 mg can be given for these patients. Next, so here the picture, let's say this is a lesion and you are going to see the dip. Here the lesion, dip. Here the lesion, dip. So these, if you see, the lesion is kind of papule. Okay, the papule kind of lesion with umbilicated center. So this is a classical lesion where you are going to see in the patients of the molluscum contagiosum. Molluscum contagiosum. And these patients is most commonly children. Okay, and if you see this in the adults, probably this is due to STD. Probably this is due to STD patients. And if you see in the children, it is due to contact, general contact of the patients. This belongs to the pox virus family, largest virus. And on the histopathology, where you are going to see the cytoplasmic bodies, these are the cytoplasmic bodies, and specific name is given for this is the Henderson and Peterson bodies. Okay, Henderson and the Peterson bodies. Henderson and the Peterson, so bodies that is seen in the histopathology of the molluscum contagiosum. Next, we have the warts. So the warts are the many types of the warts but that we see, and common warts which is known as a verruca vulgaris. Okay, common warts are known as a verruca vulgaris. These are the anal warts. Okay, these are the anal warts, which is also known as a condylema acuminata. Condylema acuminata. This is due to STD. And what is the organism that is involved here? This will be involving of the herpes virus. Sorry, human papilloma virus. This is going to have the human papilloma virus. On the biopsy, you are going to see the coilocytes. On the biopsy, you are going to see the coilocytes. Let's say common warts are due to what? Common warts are due to types like herpes, sorry, HPV1, HPV2, HPV3, and the HPV4. And if you say low risk, okay, low risk plus STD lesions, this is due to 6 and 11. And we also have the high risk. Okay, we also have the high risk. High risk STD is due to 16 and 18. 16 and 18, because this can progress the cancer also. These are the herpes, sorry, herpes, not herpes. This is a human papilloma virus. Don't confuse with this. This is a human papilloma virus. Next, moving on to the fungal infections. Remaining fungal infection we'll be discussing here. So remaining any virus infections, if it is not discussed here, you can follow up in the microbiology section. Next, coming to the fungal infections, we are going to see this condition. What is this condition, guys? We know this as a Taenia versicolor. Okay, but better name is given as a pityriasis versicolor. What does mean by the pityriasis versicolor? Pityriasis versicolor means this pityriasis is seen as a scaling. Okay, this is seen as a scaling. What type of the scaling I said? This is the brani scaling, and where you are going to see the fungus is going to act on the pigmentation. Okay, it is going to act on the pigmentation. How it is going to act on the pigmentation? It is going to use the acylic acid production. It is going to use the acylic acid production, where it is going to show the changes, most commonly hypopigmentation. Okay, hypopigmentation on special locations like trunk, back of the patient. And what is the most common organism? This is due to Malassezia furfur. Okay, but recent most common is the globosa. Furfur has a resistance, but it is occupied by the globosa, which is most common. On the KOH mount, this is the KOH mount. So on the KOH mount, you are going to see this hyphae and also mold. Hyphae, mold, hyphae, mold. So that's why this is described as a, in the KOH mount, to remember better, this is known as a spaghetti. This is a spaghetti, let's say, plus this is the molds, so meatballs. So spaghetti meatball appearances is seen in the patients of the pityriasis versicolor, right? And how it is going to present in the wood lamp, guys, as we discussed, it is presented as a yellow color. And what is the treatment that we can give? We can give the azoles. Topical azoles is given for these patients. Next, coming to the different types of the conditions that is associated with the trichophyton, microsporum, epidermophyton. These are the dermatophyte infections. Trichophyton, which will be involving of the skin, okay, and it will involve the nails, and also it is involves the hairs. Okay, simple. Try. All three structures are involved. And how it is going to look like? This is going to look like a pencil. Next, microsporum. Microsporum is only involves the two, okay, skin, and microstructure, that is nails. Sorry, this will be microsporum is involves of the hair. And how it is going to look like? This is like a spindle shape. On the microscope you are going to see. And epidermophyton, which involves the skin, and also it involves the nails. Okay, nails, that is the epidermophyton, where you are going to see this kind of the bundle shape that you are going to observe in the epidermophyton. And these points is commonly asked, which among these is the most common? The most common is the trichophyton rubrum, is the organism that is involved in the patients. And different names, Taenia capitis, Taenia versa. Some of the points that you have to remember, what is Taenia capitis? Okay, so Taenia capitis, the patient who is suffering from the hair, right? This is due to hair. And if we say Taenia pedis, this is due to foot. So like that, we have every structure in the body which will be associated with the different types of the conditions. We will be discussing that in the while. Next, here you can see this is the picture. The patient is suffering from the lesions. Okay, these lesions is raised and more than plaque size also, and this is sometimes cyst or the nodules also presentation of the patient. And what is this condition? This condition is known as a Rose Gardner's disease. This is known as a Rose Gardner's disease, as a common name for the generals, okay, general people. But this condition in our textbooks is known as a sporotrichosis. Sporotrichosis. Most commonly, this is associated with the sporothrix. Okay, this is caused by the sporothrix microorganisms, and it is following. If you observe, this is following the lymphatic route. This is following the lymphatic route for the spreading of the lesions. And why it is known as a Rose Gardner's disease? Because it is due to thorn prick. Okay, thorn prick conditions, the patients can develop this rose Gardner's disease, and this is the linear pattern, only the condition where you are going to see the linear pattern. On the biopsy, this is the biopsy picture where you are going to see the asteroid color bodies. Okay, this is like a asteroid bodies that you are going to observe in the sporothrix condition. Next, here you can see this condition looks like verrucous, okay, rough, okay, cauliflower lesions, and severely the skin is involved. Severe skin is involved. Larger area is involved. So this condition is known as a chromoblastomycosis. This is a chromoblastomycosis condition. Especially when you see the patients will be having the typical history of farmers, okay, farmers who work with the soil without chappal or on the barefoot, they will be having this trauma. This is known as a chromoblastomycosis condition. And on the biopsy, you are going to see the copper penny, or we can also known as a medullary bodies. This is also known as a medullary bodies. Treatment for this patient is the itraconazole. Okay, same as here also. The treatment for this patient also itraconazole. Right. Next, moving on to the, not all the tinea infections are not so important, but the most important types of the tinea that you have to take note is the tinea capitis. Tinea capitis is involved. So we have two types. One is the non-inflammatory type. Okay, we have non-inflammatory type. So what is the non-inflammatory type? That means it is not going to involve the systemic side effects of the patient. So in the non-inflammatory type, we have the two types. One is known as a black dot. Okay, this is known as a black dot, and another one is known as a gray patch. Another one is known as a gray patch. So what is mean by the black dot? Here you can see the patient who is suffering from the black dot. So the patient will be having this kind of, okay, the lesion is confined only to the hair. That is what the black dot. And the patient will be having patchy alopecia which is confined to only hair. So the broken hair is seen, and very mild condition of the patient. Next, gray patch. So the patients with the gray patch, here you can see this is the tinea capitis, complete gray. The hair is gone and it is looking the gray color of the patch. So this is what gray color lesions. Okay, gray color of the lesions with alopecia, and these both alopecia are completely reversible conditions, right? This is what the black dot and the gray patch. Next, we have the inflammatory type. So these inflammatory types are danger. This can involve the surrounding structures also. One of the examples, we have favus. Okay, we have the favus, and other one is the carrion. And which looks more severe? Carrion. Okay, so carrion is severe. Why it is severe? Because it is a boggy swelling. So patient is having the boggy swelling with involvement of the lymph nodes, lymph adenopathy. So we having, let's say this is a carrion, it's look like a pus formation and head region, right? And if the patient is having the neck involvement, so this can involve the lymph nodes, so which is a danger, right? So carrion is more danger. And here you can see this is a favus, and favus also, like it is also swelling, like kind of dry swelling. So that is known as a scutula. And the question that is asked, the patients who is suffering from this condition, how we are going to treat. So the treatment for this patient is always oral fungals, not the topical fungals. Okay, not the topical fungals. What is the drug of the choice? If you have to choose from the options, you can choose the griseofulvin. Okay, griseofulvin is the drug of the choice for this patient. That is the non-inflammatory and the inflammatory type of the conditions. Next, another conditions. Yes, this is the tinea capitis. Recently, INCT question. This is the tinea corporis, involves the body. This is the PDs, which will be involving of these regions like foot, and also especially seen with the athletes. And this is the tinea barbarii, the beard region, tinea manum, which will be involving the palms and soles, tinea unguium, which will be involving of the nails. And how we are going to treat? We are going to treat with a nail liquor. Nail liquor means you are just nail polish only that was using, which will be consisting of the different types of the fungal uh, particles that we are going to use. Next, this is known as a Madura food, right? You all have know this is known as a Madura food. Most commonly, why it is known as a Madura food? It is discovered in the Tamil Nadu Madura region, which is also known as a Eumycetoma. Is known as a Eumycetoma. The organism also is a fungal name. This is known as a Maduranella mycetomatus. This is known as a Maduranella mycetomatus, and this is fungal. But we also have the bacterial, that is due to Actinomyces madurella. This is the bacterial. But how we are going to differentiate between the bacterial and the viral? So there is a pus drainage. Here you can see this is the pus drainage that you are going to see. This pus drainage, if it is due to fungal, it is going to be black color. Okay, black color granules. If it is a bacteria, this is going to have the different colors: blue, red, green granules, or yellow granules will be seen. So different types of the granules that is seen in the bacterial. Only black color, that is due to Madurella mycetomatus, that is due to fungal infection. What we can do? We can do the debridement, and if severe cases, we have to amputate the leg also in these patients. Next important one, this is the two most important guys, scabies. Scabies is most commonly presentation of the infestation. Infestation means something on our body, that is the most common one. And what is the organism that is involved here? What is the organism name? The organism name is the same with the names of the scabies only. Sarcotypes, okay, Sarcotypes scabiei. And this is a female, okay, most of the times it is a female which will be burrows under our stratum corneum, and then it start to burrows deep inside. Then we will be having that itching. Especially this is active in the nocturnal period, and patients will be having the familiar history with the family. Everyone will be having. So the patient is having a severe itching and the lesions that is known as a burrows. Okay, burrows. Especially this involves the hands, digital spaces. Digital spaces will be involved, and this is having the types. Okay, newborn, or we can say this is seen with the infant, and we also have the HIV patients. If it is involved the HIV patient, there the transmission is more severe and very thicky lesions, that is known as a Norwegian type. Okay, Norwegian type. When you look for the test, on the test you will see more than 1,000 type of the infestations. Okay, more than 1,000 plus 10,000 plus organism you are going to find. Because of their weak immune system, they're going to multiply. In the newborns, it is classically involves the palms and soles, just like everyone, and it will also involves the abdomen and also neck region. Okay, this is the classical locations of the newborn and the infant individuals. So we have to treat this as early as possible, and for the treatment we will be using most commonly permethrin. Permethrin is used in these patients. Permethrin is the common one that we are going to use, most common for the every patient, and they are given in the patients of the classical CBs. Even you or me can get this one, and also this is given in the children less than 2 years, and pregnancy patients also we can give, and crusted scabies also we can give. So all the individuals can be given with the permethrin can be given. Next, coming to the lindane. Lindane is the second most common. Lindane is not given for the pregnant patients, neurological patients, and the infants. These are the contraindications that you have to remember. Next, benzyl benzodate. Benzyl benzodate is the second most common in the Indian settings. Okay, this is given for the classical scabies, but again, it is not given for the infants. It is not given for the pregnant women. So this is a contraindication. Next, this is the bioalithrin. This is the aerosol kind of. This is given not given for the patients of the asthma. Next, Cortimeton is asked previously in the NEET PG and also INSCT. This is given for the patients of the children with the nodules. Cortimeton can be given for the children. Sulfur, it is given for the everyone. Ivermectin is only 200 UG per kg, and this is given for the super infected scabies like crusted scabies and also patients who is suffering from the HIV patients. Again, ivermectin is not given for the children less than 15 kgs, pregnant women, breastfeeding women. So the best that we can give is the permethrin for the every individual, and cortimetin C for children. This is also given for the patient, and remaining all that is not given for the patients, infants and the pregnancy women. That is the one point that you have to remember from this table. The table can be asked as an important question. Next, bullous disorders that we are going to discuss. So the first important point about the bullous disorders is what are these conditions? Bullous disorders. Most commonly, the bullous disorders is going to involve the epidermal junctions it is going to involve, and in this there will be presentation of the antibodies. Okay, there will be presentation of the multiple antibodies. These antibodies is going to kill the specific structures. What are those antibodies? So the for the Pemphigus vulgaris means most common. If you see acne vulgaris, most common. Verruca vulgaris, most common. Lupus vulgaris, most common. So the word vulgaris is it is more vulnerable to common population. That is what vulgaris mean. And what are the antibodies that is involved here? It is going to involve the desmoglein 1 and desmoglein 3. Okay, it is going to involve the desmoglein 3 and desmoglein 1. It is involved. Why desmoglein 3? Desmoglein 3 is involves the mucous membranes. And Pemphigus foliaceus, this is the second most common, and here also there will be manifestation of the antibodies presentation in the dermoepidermal junction, and here it is only involves the desmoglein 1. Okay, that's why these patients will be having no oral lesions. Okay, no oral lesions. So how can you differentiate? This is known as a flaccid bullae. This is known as a flaccid bullae, and flaccid bullae are rupture easily. Okay, rupture easily, and it will involve the mucous membranes. So you are going to see the oral lesions. You are going to see the oral lesions, and Nikolsky sign is positive. So here you can see when this bullae is ruptured, here what you are going to see the Nikolsky sign. This is what the flaccid bullae, and rupturing is easily seen with these patients. Next, the most differentiating factor here is it is a superficial bullae. Okay, it is a superficial tension bullae. It cannot rupture as much as easily as a that bullae, and post lesions you are going to see the scaling. Scaling also seen in this patient, and no oral lesions. No oral involvement, then you can remember there is a Pemphigus foliaceus. And biopsy findings. As I said, some structures biopsy findings is important. And is the Nikolsky sign is positive in this condition of the foliaceus? Yes, foliaceus also Nikolsky sign is positive. And here you can see this is your structure where you are going to see this is the dermis, this is the hypodermis, and this is the epidermis, right? So in the epidermis you are going to see there is a split, right? There is a split here that is present. So this known as a suprabasal split. Suprabasal split, where you are going to see in the vulgaris patient. Vulgaris patient you are going to see. Next, here you can see same again. This is the hypodermis, this is the dermis and epidermis, where you are going to see complete there is a disruption between the epidermis and the dermis patients, and this is known as a split, okay, of the subcorneal layer. Subcorneal layer. And acantholysis. Acantholysis is not nothing but it is removing of the attachment between the dermoepidermal junction. That is known as a acantholysis. Next, how can we confirm? We can confirm with the help of the immunofluorescence test. We can confirm with the immunofluorescence test. In the both of the immunofluorescence, you are going to see the fishnet appearances. Both will look same only because both are involving of the epidermis only. So both conditions which will be consisting of the chicken wire appearances, or we can also see the fishnet appearances, and antibodies IgG is present. Here also IgG is present. Treatment is given rituximab. Rituximab is known for the immunoglobulin inhibitor, and also we can give the steroids. So as this is an autoimmune condition, here also the treatment is steroids. Mainstay is steroids. Next, another condition. This is a bullous pemphigoid. This is an atypical one, not same as that condition. It is an atypical one. And where it is involved, it is not the dermo-epidermal junction. It is actually involving of the basement membrane. Okay, basement membrane of the skin. So B for bullous pemphigoid, B for the basement membrane, that you have to remember. And what are the antibodies that is present here? So the antibodies that is present here is the IgG plus C3. Complement C3 is present as a attackers of the bullous pemphigoid. And classically, the patients who is suffering from the bullous pemphigoid is going to be elderly, who is more than 50 years or the 60 years, and bullae is looks like a tensed bullae. This is known as a tensed bullae, and it does not rupture as much as easily as above. It does not rupture, and no oral lesions. Okay, no oral lesions, and bulla spread sign is seen. Okay, bulla spread sign is seen. What is mean by the bulla spread sign? So here you can see very bulged. It is not ruptured as much as easily, and when you press this, it is going to spread like this. Okay, it is move to the other structures also. That is known as a bulla spread sign, which is commonly seen with the bullous pemphigoid. Okay, and how you are going to treat these patients? So for the treating these patients, we can again go for the steroids. And another important points, antibodies IgG is going to attack the BP 180, okay, and also BP 230, okay, BP 230, where hemidesmosomes is attacked. Hemidesmosomes is attacked. And how can you remember this two words? Elderly patients who is having the high BP. These patients will be having this high BP. Elderly people, that you can remember. Next, this is the condition that is asked previously in the examination of the FMG. This is known as a dermatitis herpetiformis. So what is this condition, dermatitis herpetiformis? So the patients who is suffering from the celiac disease, right, they will be having this dermatomal manifestation that they are going to have. And here the involved antibodies are IgG, IgA antibodies. The treatment is, this is a gluten sensitivity, right, celiac disease. So we'll tell the patients to decrease the gluten intake or complete stop. So the patient going to have the treated by this condition that is known as a dermatitis herpetiformis. Next, moving on to the most important subject, that is a psoriasis. Okay, that is a condition of the psoriasis. This is a papillosquamous disease. Psoriasis is a papillosquamous disease, and mostly this is related to the T cell autoimmunity. T cell autoimmune disease, and where the HLA involvement is also seen. HLA CW6, and also sometimes HLA B27 is also positive, but rare, very rarely. Only who is having the arthritis, HLA B27 is positive, but for the skin it is CW6. Okay, CW6. So what happening in the patients of the psoriasis? This is going to attack the epidermis of the patient. Generally, we have the dermo-epidermal timing. Epidermal time. So this epidermal time for every person is 28 days. But in this patient, it is so much fast, it is updating its epidermal time. But the psoriasis patient, let's say this is less than 5 days. So this is less than 5 days in the patients of the psoriasis. Next, lesions. How the lesions are present in this patient? The lesions of these conditions are red. Okay, this is going to look like a red and scaly, silvery patches. Okay, and also plaques, and involves the extensors. This involves the extensors. Most commonly, here you can see elbows, knees, these kind of extensions will be seen in this patient. This is going to see in the patients of the psoriasis condition. These are the other types of the psoriasis that we will be discussing in a while. And another important points that you have to remember for the psoriasis is it is going to present with the two signs. That is the auspit sign that is positive for this patient. This is the aspirant sign, which is also known as a Gartage test. Gartage test, that is when you are scraping the lesion, you are going to see the pinpoint bleeding. That is known as a aspirant sign or the Gartage test that you are going to see. And Koebner phenomena is also present here. What is meant by the Koebner phenomena? Koebner phenomena is when you are doing the scratching, the lesion is going to spread for the surrounding lesion also. That is what the Koebner's phenomena that you are going to see in these patients. These 2 points that is commonly tested for the examination. Next, we also have the pseudo Koebner phenomena and the true Koebner phenomena. Okay, let's write here. So we have true Koebner phenomena and we also have the pseudo Koebner phenomena. What are the conditions that is involved for this both? True Koebner phenomena is seen with the psoriasis. Okay, it is autoimmune condition like lichen planus and also vitiligo. All these are autoimmune conditions. Pseudo Koebner phenomena. This is from the infections like warts, and also this is due to molluscum contagiosum. Okay, these are transient conditions due to viral infection. So true Koebner phenomena and pseudo Koebner phenomena is also asked in the examinations. Next, go by the types. Okay, this is the most common vulgaris. Okay, this is known as a psoriasis vulgaris, common type, as I said. Next, another type where you are going to see the papules. Okay, where you are going to see the papules, and these papules is known as a guttate psoriasis. Guttate psoriasis. Guttate psoriasis is commonly seen with the children post strep infection. Post strep infection, they are going to present with this guttate psoriasis. Next, another type. This is known as a inverse psoriasis. This is known as a inverse psoriasis under the folds. Okay, interdigital folds or the inside the groin lesions under the armpit. These lesions will be seen, which is known as a inverse type of the lesions. Next, coming back to here, this is known as a pustular. Okay, where you are going to see multiple pustules. This is the pustular psoriasis. These pustular psoriasis, they are going to have the fever. Okay, they are going to have the fever in this condition. That is what triggering factor where you are going to see psoriasis patient with sudden pustules and the fever that is presented. And why this is presented? The triggering factor is steroids. Okay, whenever you stop the steroids, sudden stoppage of the steroids, if you stop this, the patient can trigger with the pustular psoriasis that is going to see. Next one, this is the erythrodermate. Okay, this is known as a erythrodermic and which is also known as a exfoliative dermis. This is what the patients will be having. Almost more than 90% of the body surface area is involved in this patient. That is one of the point that you have to remember. Next, on the histology. So on the histology, there are two important abscesses that is seen in this patient. They are the two important abscesses that is present here. One is known as a Monroe's abscess. One is known as a Monroe abscess. These Monroe's abscess, which will be consisting of the neutrophils. This will be consisting of the neutrophils. Next one is the Kogoj pustule. Next one is known as a Kogaj pustule. This Kogaj pustule is present in the basal layer. Okay, this is present in the basal layer. Whereas Monroe's abscess, this is present in the corneum layer. This is present in the corneum layer. And also another point is stratum granulosum. Okay, stratum granulosum is most of the condition it is absent. This is the histological findings that you are going to see. Hyperkeratosis, parakeratosis, the common ones that will be presented in these patients. Next, nail psoriasis. This is known as a nail psoriasis. So types of the nailing that you are going to see where irregular pitting will be seen. Irregular pitting will be seen. Deformation is seen. Thickening of the skin nail, onycholysis, this is a breakdown, and discolorization. And this discoloration is known as a oil drop or the salmon patch. Oil drop or the salmon patch, which is only seen with the psoriasis. So this is a pathognomic sign that you are going to see in these patients. Treatment. Coming to the treatment part, how you are going to treat these patients. Basically, we can give the vitamin D analogs in the early stages. Okay, if you see the patient is having the only the topical which is less than, we can go for the topical treatment only. Okay, we can go for the topical treatment, and we can go for the phototherapy if it is more than 10%, and we can go for the systemic treatment when you see severe conditions. Then you can go for the methotrexate. Okay, methotrexate can be given for this patient. That is a one drug that we can choose for this patient. And other drug that we can go for is a cyclosporine. Okay, cyclosporine can be given for this patient. But pustular psoriasis, as I said, in the pustular psoriasis, I'm not going to give the steroids because steroids is triggering factor. If I stop the steroids, the patient can have. So for this patient, the drug of the choice is different. So for this patient, it is a actretin. Okay, actretin. This is a type of retinoid we can give for this patient. But again, this is a different in the pustular psoriasis in the pregnancy. Pustular psoriasis with the pregnancy patients. Let's say pregnant patient with the pustular psoriasis. Here I am going to give steroids. Okay, normal person steroids is contraindicated, but pregnancy patient steroids is a drug of the choice. That is a one point that you have to remember. And some questions can be asked due to monoclonal antibodies. What are the monoclonal antibodies that we can use for this patient? We can use the IL-23, which is known as a ustekinumab. Ustekinumab. Okay, this is a ustekinumab. Just remember like a skin ustekinumab or the ustekinumab that is seen with the IL-23 inhibitor. Next, another one is the TNF alpha inhibitor. TNF alpha inhibitor. The TNF alpha inhibitor, you all know that, right? This is the common drug, that is the infliximab. It is the infliximab that we are going to use. And we have the IL-17A inhibitor. This is known as a secukinumab. Secukinumab. More of like a skin names only. So ustekinumab or the secukinumab, these are the drugs that we are going to use for the monoclonal antibodies in the severe conditions. Next, moving on to the another condition, that is a lichen planus. Right, lichen planus, the patients again autoimmune condition who will be consisting of the 6Ps that you are going to see. Okay, 6Ps here, same like the compartment syndrome, you are going to see the 6Ps here. What are those 6Ps? The patient is having the purple like lesions, which is polygonal. Lesions are the polygonal, purple color, and papules. These are itchy, pruritic lesion, and sometimes it can produce the plaques and plain top. Okay, plain topped. Just see here. So this is look like a purple, right? Papules, polygonal, and also puritic, and also sometimes it can produce the plaques and plain top color. Right. Next, this is going to have the special feature that is known as a inside inner lesion that is presented in this patient. This pattern is known as a reticulate pattern. Reticulate pattern. This lacy white color lesions in the buccal mucosa that is present in the patients of the lichen planus. Right? Lichen planus is having some triggering factors. Okay. For example, whoever is taking the mercury, or the patients who is suffering from the HCV infection, or the patient who is taking for the beta blockers. Okay, beta blockers can worsen the conditions. Those who are taking the quinidine, okay, quinidine can increase, thiazides can decrease, thiazides can aggravate the conditions, right? Some of the salts, these drugs can be also aggravating this condition. This is the lichen planus. Another important point is they consisting of the Wickham striae. Where you are going to see the Wickham striae? Wickham striae is seen in the patients of the lichen planus under the microscope. Okay, under the microscope you are going to see this, or you can use the light or the other magnification structures also you can use for this patient. And can this involve the nails? Yes, this is also going to involve the nails of the patient. Same, the pitting will be seen in this patient. Okay, irregular pitting will be seen, and sometimes, for example, this is a nail, and sometimes this is going to fuse like this. This is known as a pterygium. Okay, the nail pterygium is seen in the patients of the lichen planus. Next, pityriasis rosacea. Pityriasis rosacea, this is caused by the HHV6 and the HHV7. And how this is going to present, guys? Especially the patients who is suffering from the cholerae scales and children who is suffering from this condition, and this is known as a first patch, mother patch. Okay, this is known as a mother patch. Other name for this is the herald patch. After coming this herald patch, you are going to see other patches. So this is the first patch or the mother patch, and over the time it can spread to the trunk. So how does it looking like? So this is looking like a Christian tree appearances. Christian tree appearances where you are going to see Christian tree appearances. This is seen in the pityriasis rosacea and cholerae scaly. Right, these 2 points is important, and you just have to do the supportive treatment for this patient. Next, what is this condition, guys? This is a genetic defect. This is albinism. Patient is suffering from the albinism, and the deficiency is tyrosinase. Tyrosinase enzyme is deficient in this patient. Next, this is autoimmune condition which is known as a vitiligo. This is the autoimmune condition vitiligo where most of the melanocytes is deficient in this patient. So most of the melanocytes that is deficient in this patient. 1 point. Next, this is the autosomal dominant condition. This is the autosomal dominant condition. This is known as a pibaldism. Involve the forehead and also hair. This is known as a pibaldism. Types of the conditions that you are going to see, different types of the hypopigmentation lesions. Next, another two conditions that you can see here. So this is melasma. This is a melasma in the women, especially who is taking the OCP. They are going to have, and chlasma. Okay, chlasma. This is seen in the pregnancy patients. Okay, due to the estrogen. Next, this is the condition of the pityriasis alba. This is not a hypopigmentation. This is a inflammatory scaling, and it is reversible conditions. Okay, this is a reversible conditions seen in the children. So most of the times this is actually due to micronutrient deficiency. Micronutrient deficiency. This is the pityriasis alba, and remember this is a non-pigmentary condition. Non-pigmentary condition. Next, another three types. This is the most confusion where the patients. First is the Becker nevus, where you are going to see the Becker nevus. So the patient, like say the male patient, most of the times males and adolescents, especially after the puberty, this is a unilateral involvement of the shoulder with pigmentation. Increased pigmentation is also seen. That pigmentation is covered by the hair. Okay, hair growth is seen unilaterally. Okay, this is a unilateral condition that you are going to see. Nevus of Otto. What is the nevus of Otto? The nevus of Otto is involves the cornea and also unilateral of the trigeminal nerve. Trigeminal nerve involvement and also the skin towards that cornea side. So this is known as a nevus of Otto. Cornea, okay, O and Otto. That's how you can remember this one. And can you see the hair? No hair is seen in this patient. Nevus of Ito. Nevus of Ito, this is no hair, right? Where you are going to see no hair, and the patient is most of the times babies, infants, involves the shoulder, and nerves are involved here. What are those nerves? So the nerves that is involved here is a supraclavicular nerve or the scapular nerve that is involved. So the no nerve involvement is the here Becker nevus. The nerve trigeminal is for the Otto. Ito, it is a supraclavicular nerve that is involved most of the times. Next, we will be moving on to the acne. Okay, this is the acne conditions. In the acne conditions, there are the four grades that is given. So first grade, you are going to see only the comedones. Okay, black and white comedones is seen in this patients. So for this patient, Black and white is nothing but these are the open comedones and this is the closed comedones. So for these patients, what we can give? We can simply give the topicals or we can just wait and watch. Typically, they are going to regress. That is what with the grade 1. Even most of us will be also having this during the puberty or sometimes due to the skin irritation also. Next, grade 2. It is going to aggressive, like it is going to present with the papules and also pustules. So for these patients, my treatment will be changed. So for this, I must should give the topicals, especially retinoids, and along with that, the pustules are seen. So if the pustules are involved, that is due to Propionibacteria or the QT bacteria. So for them, I have to treat with the antibiotics, and antibiotics are also most commonly topical antibiotics that I'm going to treat. Next, grade 3. Grade 3 is further aggressed completely. It is going to be the pustules. Okay, sometimes it is going to be pus and also nodules. Nodules are plus or minus. Pus will be seen, pustules will be seen, and painful. Sometimes these are painful. So for this also, my treatment plan will be changed. And here I'm going to give the topical. Still, retinoids is my first choice, and after that I'm going to add the oral antibiotics. Okay, oral antibiotics that I'm going to add for this patient, and these are nodules and also cyst, and sometimes the patient will be having the fever plus or minus and very much irritative in the patients. Okay, this is very much irritative for this patient. For this, we are going to use for the oral retinoids. One of the examples is isotretinoin. Can isotretinoin given for the patients who is going to pregnant or who is already pregnant? No, isotretinoin is not given for the patients of the these conditions. Next, another condition that you can see here, this is a rosacea. So this rosacea is a type of inflammatory condition. This is a type of inflammatory conditions. Especially this is seen in the females who is between the 25 to 45 years of the age. This can be due to the hot climate or the patient who is sensitive. Okay, this erythema is seen. Okay, less lesions but erythema is seen. If it is involves the males can develop the rhinopima. Patient can develop the rhinopima. Next, the only cancer that I want to discuss, because this is recently asked in the INCT in the last year also, so melanoma. Okay, only according to the India that you have to take note. The most common type of the melanoma in India is acral lentiginous melanoma. And what is the most common site? Palms and soles. Okay, palms and the soles. And what is the spreading worldwide? Worldwide, the superficial spreading is the worldwide, but the important prognostic factor is the Berslow thickness. How much is the tumor length? The worst prognosis is the distance metastasis, most commonly to the lungs. And ABCD criteria is used in the which patients? That is used in the patients of the uh, melanoma. A for asymmetry, B for the border, C for the color variation, D for diameter more than 6 mm, and E for evolution, different types of the changes that you are going to see. And histopathology, S100 positive, HMB 45 positive, melan 5, and atypical melanocytes from the dermis and the epidermis that you are going to see. The most common mutation, it is a BARF mutation that is the most commonly associated. And what you can go for do, we can go for the sentinel lymph node biopsy also. Nail melanoma clue, which you are going to see, this is also known as a Hutchinson sign, that is seen in the lateral nail fold. These are the questions that is asked. What is the most common site is asked, palms and soles. What is the most common type? Aclar lentiginous. All these points are important as per the Indian. Okay, because if it is international or the worldwide, it will be different, but Indian points that you have to remember. Next, hair and nail disorders that you have to recall once again. So here we are looking for the alopecia areata. This is known as a alopecia areata. Okay, where you are going to see the patches. This is the patches that you are going to observe, and on the microscopy where you are going to see the broken hair, and that broken hair is looking like a exclamation mark. This will look like a exclamation mark. And what is the treatment of the choice for this patient? The treatment of the choice for this patient is the steroids. Okay, This is an autoimmune condition where we can give the steroids for this patient. Next, male pattern baldness, which involves the vertex, the most commonly vertex that is involved in the patients, right? Okay, this patients is mostly due to testosterone. Okay, testosterone that is converted as a dehydrotestosterone. Dehydrotestosterone is converted. This dehydrotestosterone can damage the hair follicles, which resulted the patient into the alopecia, especially that is present in the parietal on the frontal region the patients will be having. And what is the best treatment of the choice for this patient? The best treatment of the choice for this patient, minoxidil. It is a type of vasoconstrictor. It can give the uh, best treatment for this condition. And we also have the finasteride. Finasteride is going to stop the conversion. Okay, it is going to block here. This is the 5 alpha reductase enzyme. It is going to block, and we can also give the spironolactone. Spironolactone is going to act on the androgens. That is also going to increase the testosterone and best for the growth. And ultimate stages, they can go for the basically for the hair transplant. So in the female pattern, it will include the center. It will include the center most of the times. Still, the frontal hair will be present. Next, coming to this picture. This picture just I discussed yesterday also. This is a type of a OCD, the patient who is having trichotillomania. Trichotillomania is a type of OCD, and they are going to picking up. So hair picking up, and they eat. If they eat, they can develop the trichopizar. It's an emergency condition, psychiatric emergency condition that you are going to see. Next, another two conditions that you have to remember. What are those? One is anagen effluvium, and telogen effluvium. What are these two conditions? Anagen effluvium and the telogen effluvium. Let's understand. So anagen effluvium, this is going to involve the anagen phase of the hairs, and this involves the telogen phase of the hair. This anagen patients is mostly who is having the history of chemotherapy. Okay, in the movies we see they're having the hair loss that is due to chemotherapy. This is known as an anagen effluvium. Telogen effluvium, this is mostly due to stress. The patient is having some stress, economical, financial stress, or patient who is having the infection is also going to associated with the telogen effluvium. They post infection. For example, there is a question that is asked: patient is suffered the COVID-19 and after they are having the hair fall. So that is a telogen effluvium due to post stress that is attacked these hair cells. And all these we discussed now, all are considered as a reversible causes. All are considered as a reversible causes. Next, this is known as a koilonychia or spoon-shaped needles. Sorry, spoon-shaped nails. This is seen in the iron deficiency anemia. Who is females? Who most of the females are consisting of the iron deficiency anemia. Next, here you can see this is a pitting. Pitting could be regular or pitting can be irregular. Remember, if it is irregular, choose the psoriasis. Okay, different. This is how they are going to present. Regular, they are going to present in the regular manner only. This is seen in the alopecia areata. Alopecia areata, regular pitting. Next, so here you can see this is the lines known as a view lines. This is known as a view lines, and these view lines is seen in the patients of the coronary artery syndrome. This is seen in the coronary diseases, decreased calcium levels, and also trauma. Next, this is known as a clubbing, seen with the patients of the COPD, right? COPD patients and severe heart conditions like congenital heart diseases or the valvular stenosis patients. And this is the onychomycosis fungal infection. This is a fungal infection where you are going to treat with the nail polish that is known as a nail lacquer. This is known as a leukonychia who is suffering from the malnutrition. You can check your nails. Sometimes we are deficient with the malnutrition, right? We also have that separate two conditions. Some patients with the liver disease, they are going to consist, and some patients with the kidney patients. Okay, kidney. So kidney condition also they are consisting. And another one is the me lines. Me lines. So let's see what are these. So who is suffering from the liver? This is the terminals. These are known as a terminals. These CKD patients or the chronic kidney disease patients, this is known as a Lindsay nails. Lindsay nails. May lines is seen in the patients of the arsenic poisoning and also thallium poisoning. Thallium poisoning that you are going to see. For example, this is the nail where you are going to see multiple lines. That is the arsenic poisoning. Lindsay nails, it is going to have the only the superficial structure is involved, and Lindsay nails the only the distal surface is involved. Sorry, this is the distal, this is the superficial, like that. This is a differentiated, but you are going to have the in the question the history of the liver and the kidney or diseases is given for those patients. Next, moving on to the genital lesions. Moving on to the different type of STDs that you have to recall. So first, chancroid. Chancroid is caused by the which organism? Chancroid is caused by the Haemophilus ducreyi. This is due to involvement of the Haemophilus ducreyi. And syphilis is due to Trypanosoma pallidum. Trypanosoma pallidum. And lymphogranuloma venerum. This is going to due to involving of the chlamydia infection, and donovenosis. This is due to Klebsiella granulomatous. Next, coming to the lesions, how you are going to differentiate. So first, we are differentiating with the pain and painless and lymphadenopathy. Ducreyi is very hard. Okay, remember Ducreyi hard Ducreyi, DD, and this is painful ulcer, and also painful lymphadenopathy. Painful lymphadenopathy is seen here. Next, the patients who is suffering from the syphilis, this is the primary chancroid. This is the primary chancroid, which is painless. Patients will be having the painless and also painless rubbery lymphadenopathy. Okay, bilateral lymphadenopathy that is painless. 1 point. Next, coming to the LGV, this is a lymphogranuloma. So here there will be ulcer which is painless, okay, and painful buboes. These swellings are painful. These swellings are painful buboes. That is seen in the severe condition. The genitals, if it is increased, that is known as a painful buboes. So this is a lymphadenopathy, and this sign, this is another line. This is a line they are giving the tract. This tract name is known as a groove sign. Next, coming to the donovenosis. This looks like painful, right? But this is not a painful. This is a painless condition. Okay, painless ulcer, beefy red color. Beefy red color ulcer that you are going to see, and no lymph nodes. No lymph node swelling is present. Is only in the Klebsiella granulomatous. And what is the treatment? So treatment here is the azithromycin. This is going to be the azithromycin. Here it is going to be the penicillin. Here it is going to be the penicillin. And next in the lymphogranuloma, here I'm going to give the doxycycline. And again Klebsiella is azithromycin. Right? This is how you can take note of the difference of these conditions. Next, coming to the patients who is suffering from the tuberculosis. Okay, this is the conditions of the TB. So TB skin is involved by the lupus vulgaris. Lupus vulgaris is a misnomer. This is not a lupus condition. This is a misnomer. And most commonly, which is also known as a verrucous plaques lesion. See, this is a verrucous plaque lesion that is patient is presented. Superficial and most commonly face is involved in this patient. And as I said, when you do that diascopy with this using the slide, what is going to present? Apple jelly nodules. Apple jelly nodules granuloma is presented here, and no blanching. Next, coming to the second type. So this is a type that is most commonly seen in the cervical lymph node involvements. The condition that is known as here is a scrofloderma. Scrofloderma. C for cervical, C for scrofloderma, and C for children. Okay, pus is coming out here. This is how the patients will be presented. This abscess is seen, and this abscess is painless. This is a painless. That's why we also call this as a cold abscess. Most of the TB patients will be having the cold abscess only. They don't even feel the pain. Next, this is the TB verrucous. Verruca means rough. Okay, cutis. Okay, verruca cutis, where you are going to see like wart-like lesions and verrucous lesions that is seen in this patient. So this is the some types of the skin lesions that you can remember. Next, moving on to the Ridley-Joplin classification. Ridley-Joplin classification is given for the Hansen's disease. So don't confuse what is this Hansen's disease. This is nothing but the leprosy, which is caused by the Mycobacterium leprae condition. This is due to Mycobacterium leprae conditions. Next, we have the different types. Okay, and the most common in India, that is a BT. Okay, BT or that is common with the our F preparation, right? So just remember BT. That is most common in India, and rarely they're going to ask in the worldwide, but if you have to choose for the worldwide is a BB. Next, how can we differentiate this different types of the lesions? So early is going to present with the tuberculoid lesions. They're going to be 1 to 3 skin lesions. Okay, these present like a patches more than 1 centimeters, hypopigmented patches, hypopigmented annular. Annular lesions means circular. So when you are see the circular, they are well defined, right? You can differentiate between the skin, but they are central clearing. These are central clearing that is seen here in the patients, and they look like saucer shape, right? So if you can appreciate, this is the outer skin, this is the middle skin that look like a saucer shape. Next, moving on to the BT. BT is common in India. So this is like 3 to 10 lesions that is present. 3 to 10 lesions and no well defining. Okay, so here, so this is the lesions. So no well defined markers and satellite lesions. So as I said, so this lesions is present like a satellite lesions. Surrounding lesions that will be presented. And here it is more than 10 lesions. So multiple, here you can see multiple lesions will be seen, and this is like a geography lesions. Geography lesions. Geography lesions are seen here. Punched out. These are punched out lesions. Next, borderline lepromatous. Borderline lepromatous is almost like nerve is involved. Nerve is involved. So much thick lesions. These are so much thick lesions and inverse saucer shape. Okay, they are like inverse saucer shape. Inverse saucer shape that is seen in this patient. Next, lepromatous leprae. This is a severe condition. This is a severe conditions where you are going to see the nodules and leonine faces, deformities. The face is asymmetry. The lesions are asymmetry and multiple nodules that is going to see. And nerve is severely involvement. This nerve involvement is known as a glove stalk deformity. That means where you are going to put the gloves and stalks, that is going to nerve involvement is seen in this patients. So the points that you have to remember is the what is the most common nerve that is involved. The most common nerve is the ulnar nerve. Overall, the most common. If you they ask most common cranial nerve, then you can choose the facial. What is the most common peripheral type? What is the most common peripheral type? From the spinal cord, that is the greater auricular nerve, where your beard area, greater auricular nerve that is involved here. Next, what is the most common sensation that is involved? So the patient will be deficient with the temperature, and in that cold is the first one, then the hot. Cold is the first one, then the hot. That is a 1 point. Next, we have the differentiation between the two things. Okay, first, what is a paucibacillary? What is a multibacillary? So what is the paucibacillary and multibacilli? Bacilli is nothing but how much is the organism. These are the bacilli organism, Mycobacterium leprae. So 1 to 5 lesions. This is more than 5 lesions. Nerve is not involved. Here the nerve is involved. Must ensure there is a nerve involvement, and treatment will depends on here 6 months treatment, and this is nerve is involved. We are going to give the 12 months treatment for this patient. And how you are going to give the treatment? So drugs that we use for this patient is a dapsone, clofazimine, and also rifampicin, right? Clofazimine can cause the side effect pigmentation. This is also PYQ, that is brown pigmentation is seen. Dapsone can cause the hemolysis, and rifampicin can cause the orange color fluids. Okay, orange fluids. Dosage and everything we will be discussing in the PSM. Next, this is going to have the reactions, right? The reactions is important. Type 1 reaction and also type 2 reaction. So type 1 reactions is going to have the skin lesions plus nerve involvement. So if it is nerve is involved, then it is so painful. Type 2 is only skin lesions. Type 2 is only skin lesions, but these lesions are extensive, severe extensive lesions that is seen. So question that comes here, can we continue the treatment or not? Yes, we have to continue the treatment, and we can add the steroids to decrease this pain. And same as here, can I continue the treatment? Yes, the treatment has to be continued. You should not withdraw. Where you can add the thalidomide. Here you can add the thalidomide. And hypersensitivity, in the sense of the hypersensitivity, this is the hypersensitivity reaction of 4, and this is the hypersensitivity reaction of 3. Rule of 5, right? So this is the important points that you have to remember about these conditions. Next, coming to the some of the most important table, guys, different types of the kits that you have to remember. So kit 1 is for the gray color. Kit 1 is for the gray color, urethral discharge, scrotal swelling, cervical discharge. The drugs that you are going to give, azithromycin or the ceftoxamine. Green color is for the vaginal discharge, secundazole or the fluconazole is given. Gray, that is third one, is the white color. This is for the genital ulcer non-herpetic type, where you are going to give the penicillin. And fourth one is for the blue color. This is for the ulcers, again non-herpetic, doxycycline, azithromycin is given. And fifth one, red color, is the herpetic one, that is given for the acyclovir. And sixth one is the yellow color, lower abdominal pain, cefixime, metronidazole, doxycycline is given. Seventh is the inguinal bubo for the azithromycin, and the doxycycline is given for these patients. Next, some of the conditions that I wanted to discuss here, and these conditions are frequently or recently is also asked as. What are these conditions? Let's see one by one. So the patients here, you can see this is the kids, right? So the first kid that is presented here is the patients with suffering from the tuberous sclerosis. This is known as a tuberous sclerosis. So this is known as a adenoma sebacum. This is known as a adenoma sebacum that is seen in these patients. And here you are going to see the hypopigmented lesion that you are going to see, and heart valves is involved, and retinal involvement is seen, and there is a fibrosis, and this thickening of the skin, this thickening is seen. All this will be seen in the patients of the tuberous sclerosis. Coming to this condition, this is the neurofibromatosis. In the neurofibromatosis, in the eye, there will be hamartomas, which is known as the leash nodules, and optic gliomas, neurofibromatous lesions, and pectus excavatum, and axillary freckling, which will be seen in these patients, and also capillate spots, and also groin freckling, which will be seen in this condition. And scoliosis also one of the presentation. Next, coming to the another condition that you can see, this is a very severe condition, right? So the patient is having the severe condition. What is this condition? This condition is known as a Darier's disease. This is known as a Darier's disease. So this Darier's disease is seen in the genetic conditions. Okay, whenever there is a deficient in the calcium channel of the skin, so these patients will be having. So very dirty color, warty color, greasy color papules that you are going to see in the seborrheic areas. On the seborrheic areas that you are going to see in this patient, and it's a type of ATP2A deficiency gene. ATP2A2 deficiency is seen in this patient. This is what the Darier's disease. Next, another conditions. This is known as a Hailey-Hailey disease. This is known as a Hailey-Hailey disease. Hailey-Hailey disease is due to ATP-C1 gene mutation, and here also the calcium channel is defective in this patient, but it is only involves the flexure areas. This involves the only flexure areas. This involves the seborrheic areas. Seborrheic areas that is involved in this patient, and this is a Darrier sign. This is the Darrier sign. Darrier sign is different from this case. Darrier sign means the patient is having the, whenever this is the actually histamine. So when you scratch this, this will be increase the histamine. Okay, you are increasing the histamine, that is going to known as a Darrier sign. And this one is the port wine stain. This is known as a port wine stain seen in the patients of the this condition of port wine stain. There is a, here you can see, and inside the brain also there will be having the leptomeningeus infection also seen in this patient. The condition name is the Sturge-Weber syndrome. This condition name is known as a Sturge-Weber syndrome. And what about this condition? This is known as a epidermolysis bullosa. Epidermolysis bullosa condition. In the epidermolysis bullosa, this is a congenital condition where you are going to see epidermis is splitting. Okay, epidermis is splitting is a congenital condition that we are going to see in this patients. And another important point that you have to take note about the patch testing. When we are going to do the patch testing and how you are going to interpret those patch testing. So for example, if you see the patient whoever is suffering from the patch test, at what time we are going to test? Basically, the patch test is done for this patient, and the best results, the reading can be taken for the 48 hours. So 48 hours we can call the patient. Okay, you can read, but the best results is get by the 96 hours. This is where we are going to get the 96 hours. The best results will be seen in this patient. So this is how we are going to differentiate this one. This is what how we are going to differentiate. Next, some of the dermatitis names that you have to remember. So for example, what are the dermatitis that is going to cause? The metal infection can cause by the nickel. Metal infection can cause by the nickel. And in India, bindi, whenever the tickly that is put on the patients, that is due to paratetracyl butyl phenyrate that is involved in the patients. And if it is a dye patients, this is due to paraphenylene diamine, that is paraphenylene diamine that can be caused. These three questions is also asked previously. So these are the some of the important points that you have to remember and recall, guys. And at least if you can recall these questions now, you can easily answer all the questions, right? So this is how we have discussed and important points. Please do cover in your Q bank also, so that you can maximum score from the dermatology at least 5 or 6 questions. So those who are new to this channel, please do subscribe and share with your friends, and don't forget to like the video so that it can reach the more students. Until then, see you guys. Happy preparation.